Hi, this is Brian Kim. I want to share with you this case of a patient who has a secluded pupil with posterior synechia, and this is a really dense lens. This is a Catarock, and you're going to see terminal chop sculpting and then supporting the lens from the periphery to enable a more efficient sculpting, and then cracking and separating the two heminuclei, cross chop, and then performing scissoring chop where I'm amputating the posterior adhesions, and then performing mechanical fracturing techniques to mash up the pieces into smaller pieces, utilizing less ultrasonic energy and protecting the corneal endothelium in the process. So you can see here, this is the dense lens with a secluded pupil with posterior synechia and adhesions. I use a cotton tip to steady the eye, and then using a corneal marker to help me center incisor rexus. I'm using a paracentesis blade first on the right side and then the left side, making sure the incision is parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then some dispersive viscoelastic. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then enter. And then I'm going to use that viscoelastic to help visco dissect some of the adhesions off the anterior lens capsule, just sweeping the peripheral iris off the anterior capsule. So that looks pretty good. Go ahead and use the Haldi-Perkar. These are the blunt tip forceps. Again, this is an older case. I puncture the center, pull down, grab the right side of the tear, and then go around circumferentially. Grabbing and re-grabbing as I go. Again, you can see this is a pretty dense lens. Finish off the rexus, burp some viscoelastic out. Wanting to make sure that I got the entire rexus off. Finished it off, burp some viscoelastic out. This is the capsular fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally, point the tip down, get a nice wave. Decompress on the left side, sweeping underneath the rexus edge on the left side, turning the cannula to the right, hooking the peripheral lens, and the lens begins to spin. Irrigating the surface of the eye, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material. And then I'm turning to bevel up, and then I'm going to begin to sculpt. I'm sculpting. You can see this pretty dense lens. You see the lens is a little wobbly, and that's probably because of weak zonules. So to place the chopper out to the equator, and I'm able to support it from the periphery. You see that? You see how much more efficient the sculpting is because I'm holding it from the other side, and I'm not depending upon the zonules to hold the lens as I sculpt. As you know, the zonules have no friends, and so if you damage the zonules, that's not good for you. So I place the chopper out for some additional support. I perform the terminal chop, and I'm able to fracture the lens on that side. It didn't propagate all the way to the subincisional area. So now I'm going to spin the lens 180 degrees very slowly and carefully here. And the lens is nice and mobile here. Place the chopper around the lens from the equatorial side, again fracturing from the terminal side. And now you can see this is two separated heminuclei completely with that terminal chop maneuver. Place the chopper around the right heminucleus, pulling it centrally toward the phaco tip, which is positioned deep in the bag, and I'm able to fracture that lens in half. I turn the bevel now down, lift that first quadrant up with some vacuum, fracturing the lens by sandwiching the lens pieces between the instruments, utilizing some ultrasonic energy and some vacuum to remove the lens pieces. primarily focusing on mechanical fracturing forces to break the pieces into smaller pieces, and then emulsifying the lens. That's the second quadrant, placing the chopper around the lens piece, pulling it centrally toward the phaco tip, making sure I'm hooking it. You can feel when you actually hooked it because there's that force. You can have that tactile sensation. And once I fracture it, I'll lift that fragment up with some vacuum, sandwiching the lens pieces between the instruments, crushing it again and again, and then emulsifying the lens piece when it's small enough. Using some vacuum to lift that piece up, sandwiching the lens piece between the instruments, crushing it into smaller and smaller pieces, using some vacuum to grab it again, and then crushing it between the instruments, pulsing it with a little bit of ultrasonic energy, and emulsifying those lens pieces. Sandwiching the lens pieces again when they're too big, crushing it between the instruments, and then emulsifying the lens pieces. So that is now half the lens is out. I'm turning the second heminucleus in front of me, placing the chopper around the lens piece completely, placing the phaco tip a little bit deeper, fracturing and bisecting that lens piece, performing the same maneuver around the third quadrant, placing the chopper around the lens, pulling it centrally toward the phaco tip, and crushing the lens between the instruments. Crushing the lens between the instruments once again into smaller and smaller pieces, and then emulsifying the lens piece with high vacuum and bursts of ultrasonic energy. You can see there's exquisite control, chamber stability. I'm not going after pieces with the phaco tip. I'm not using vacuum to try to grab pieces with high vacuum within the capsular bag, which is quite dangerous if you do it that way. I'm just using mechanical forces to crush the lens pieces. I have exquisite control as I'm disassembling the lens. Again, because I'm not utilizing ultrasonic energy or vacuum, I'm just using mechanical forces under irrigation only, positioning the lens piece so that the instruments are around the lens piece, crushing the lens piece into smaller and smaller pieces as I do this. And all that takes is just learning how to position the instruments around the lens piece and then fracturing the lens. You just have to have equal opposing forces, and it really works very, very well, as you can see here. Just injecting some more dispersive viscoelastic to coat the corneal endothelium before I remove these last pieces, and also to push the posterior capsule back. There was some lens material that was in the subincisional space, so I used a viscoelastic to push it out in front of me. So again, this is just with irrigation. I'm just positioning the lens between the instruments. And so that's really that's part of the learning curve, knowing how to do that. Again, very different from how we were taught. You're supposed to, just grab it with high vacuum. But by doing it this way, you can crush the lens while the eye is filled with viscoelastic. So what happens is, you fill the eye with viscoelastic, you're trying to protect the cornea. So then what? You go after it with vacuum. So you inflated the eye with viscoelastic, you go after the lens pieces using vacuum, and what happens? You remove all the viscoelastic you just put in. It makes no sense. So I filled the eye with viscoelastic, protecting the cornea, pushing the posterior capsule back, and then just using mechanical forces, I'm able to crush the lens pieces using pure mechanical forces, crushing the lens into smaller pieces. I get the phaco tip right up to the lens material, and then I'm able to emulsify it. So I take the chopper out, push PSS in, take the phaco tip out, and I go in with the ironing handpiece. There's a small fragment there. I'm mashing the tip of it with the cannula into the port. Start subincisionally removing the cortical material from anterior to posterior. So again, that goes back to what I was saying, we're taught to grab lens pieces with vacuum. Well, if you're trying to protect the corneal endothelium and push the posterior capsule back, and I pushed all that OVD in there, and the first thing I do is activate vacuum, that makes no sense. So I'll switch to polish mode, polishing underneath the rexus edge, and then switching to cortex mode as needed if there's any remaining lens material. So by relying on mechanical fracturing forces instead to fracture the lens, it just means you have to learn how to position the lens pieces with opposing forces so that you can crush it effectively rather than miss and just kind of sideswipe the lens piece. And again, that just takes practice. And when you do it that way, I'm able to mash the pieces into smaller pieces. Again, the eye is still full of viscoelastic, and I'm able to still protect the cornea and the posterior capsule, and then get the fingertip right up to the piece, and then use some vacuum to eat the piece up. And that, by doing it that way, you're able to keep as much viscoelastic in the eye. That's very, very important. So I fill the eye with cohesive viscoelastic, and now I'm sweeping on the left side and then the right side with the capsule sweep. And because this is a dense lens, I'm going to widen the incision with my paracentesis blade. Go in, bevel down, turn the bevel to the left, deliver the leading haptic into the bag. As the optic comes out, I rotate my wrist 90 degrees counterclockwise so the optic comes out flat. I dial the trailing haptic by pushing the optic-haptic junction with the Maltzman. I go in with irrigation off, activate irrigation, go underneath the lens, removing the viscoelastic from within the bag. Switch to polish mode, polishing underneath the rexus edge, and then going to visco mode, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a secluded pupil, posterior synechiae. I visco dissected the synechiae off the anterior lens capsule. You saw terminal chop, cross chop, scissoring chop techniques. Again, going back to my point before, viscoelastic is necessary to protect structures inside the eye. But this is a tug of war effect because when you're using the vacuum from the phaco machine and the aspiration, you're sucking out viscoelastic as well. Ideally, you keep the viscoelastic in and you're only removing lens pieces, but of course it doesn't work that way. The vacuum doesn't care, it's indiscriminate. It goes after and sucks out whatever is in front of it. And so, you fill the eye with viscoelastic and then you're trying to grab a piece, and what do? You use vacuum to try to grab the piece, but then you remove viscoelastic in the process. It makes no sense. And so rather than going after pieces with vacuum and aspiration, it makes more sense to crush the lens piece into smaller and smaller pieces, and then you can get the fingertip right up to the lens piece, emulsify the lens piece. By doing it that way, you're able to keep as much viscoelastic in the eye, which protects the corneal endothelium and also coats and protects and pushes back the posterior capsule as well. And so that's another reason why it makes a lot of sense to utilize mechanical fracturing forces to disassemble the lens rather than trying to grab pieces with high vacuum, especially if it's in the capsular bag. You don't want to bring the vacuum deep into the capsular bag going after pieces when the posterior capsule is exposed. Just use a chopper, use your instruments to manipulate the lens pieces up out of the bag. And to me, this is why this is the best way to do cataract surgery, in my opinion. So I hope this was helpful to you, and I thank you for your attention.